today we'll be discussing about steroid, right? We know steroids have mainly two kinds of action. One set of action is mediated by the glucocorticoid receptor. Another set of action is mediated by the mineralocorticoid receptor. So let us classify. Remember it very easily. I'll provide you with a framework. Same goes this side also. Right. So this is pure mineralocorticoid action. From here forward, we'll call it MC, right? And here in this extreme, this is pure glucocorticoid action. From now onwards, we'll call it GC, right? So in the middle lies something that is in between both these two. I mean 50% mineralocorticoid and 50% glucocorticoid. That is hydrocortisone, right? Of course, the mineralocorticoid action is greater than the glucocorticoid, but nevertheless, hydrocortisone has both mineralocorticoid and glucocorticoid receptor action, right? Now, if you go this way, we have a pure mineralocorticoid, that is fludrocortisone, 100% mineralocorticoid, no glucocorticoid activity. Fludrocortisone. This is pure mineralocorticoid. This is mix. If we come this way, we have two intermediate things. So the pure glucocorticoid action, we have dexamethasone. No mineralocorticoid action. We have betamethasone. No mineralocorticoid action. Right? And in between, we have two things. As you progress in this ladder in this way, we have first one is balanced GR with some mineralocorticoid action, that is prednisone or prednisolone, right? And another predominantly, this is predominantly glucocorticoid with very less mineralocorticoid receptor, and this is methylprednisolone, right? So this is how it is classified. You take the hydrocortisone as the midman, as the middleman, and there are two extremes. One is pure mineralocorticoid action, one is pure glucocorticoid action. Fludrocortisone belongs to the cortisol that has 100% mineralocorticoid action. Dexamethasone and betamethasone are the steroids who have pure glucocorticoid action, no mineralocorticoid action. Right? So how we will compare these things? Usually we take hydrocortisone 200 milligram. If hydrocortisone is 200 milligram, as it goes this way, the strength is increasing. The mineralocorticoid action increasing, so the dose of fludrocortisone will be less. So 200 milligram of hydrocortisone will be equal to 10 milligram of fludrocortisone. Similarly, in this way also, if you go, the GR activity increases, so the dose also will be decreased, right? So 200 milligram of hydrocortisone is equal to 50 milligram of prednisone or prednisolone, 40 milligram of methylprednisolone, and approximately 8 milligram of dexamethasone. Right. So this is the comparative calculation. So if in a patient you want to give 200 milligram of hydrocortisone, the consultant says convert it into methylprednisolone. This is the formula you have to use. Right. Now based on this framework, we will now discuss in different disease condition in the ICU why we choose specific steroid, right? What is the rationale behind it? And before going to the discussion, let us first learn a little bit of physiology. So if this is the adrenal, there is a part of adrenal that secretes aldosterone. There is a part of adrenal that secretes cortisone. All these things, right? So when and it is being controlled by pituitary and hypothalamus. From hypothalamus to pituitary, from pituitary to. So in secondary adrenal insufficiency and tertiary adrenal insufficiency, only the part of the adrenal that produces cortisone is affected. As you know, this aldosterone producing area, this is independent of pituitary and hypothalamus. This is controlled by something called RAS system, right? But in the primary adrenal insufficiency, that is complete adrenal failure. So here there will be problem with aldosterone secretion also, plus problem with secretion of cortisone, both. So that's why the treatment of primary adrenal insufficiency and secondary adrenal insufficiency differs by a little bit. That we'll discuss in our further discussion, right? So steroid in ICU has two action. One is mineralocorticoid action, one is glucocorticoid receptor based action. So mineralocorticoid based action, basically it covers stress. So the stress coverage, right? What does it mean? It increase vasoreactivity in stressful situation. For example, in sepsis, it will increase the vasoreactivity. Also, because it works on the sodium and H plus receptor, it increases the mean systolic filling pressure by accumulating fluid and sodium, right? Now, how we use this mineralocorticoid receptor action in our ICU? Number one is in, as you discussed, in primary adrenal insufficiency. We know in primary adrenal insufficiency, both aldosterone is not there, also cortisones are not there. So here we need some agent who has both glucocorticoid action and mineralocorticoid action. So what is the best drug here? We have IV hydrocortisone, right? Why not DEXA here? Because DEXA is a pure glucocorticoid. We need mineralocorticoid action. So DEXA, prednisone, methylprednisolone, all these are not valid in primary AI. We have to give IV hydrocortisone, right? Second, where we use it? In SARSI. There's also a refractory septic shock. Refractory means refractory to fluid and vasopressors, mainly noradrenaline. Here also we'll use IV hydrocortisone. Plus minus oral fludrocortisone. As you know, in this situation, the whole adrenal is involved. So if you want more mineralocorticoid action, more volume, more vasoreactivity, then you can add oral fludrocortisone. Same here in primary AI also, you can use PO fludrocortisone. But usually, what is done in the beginning, we start with IV hydrocortisone, and when we wean the patient to oral, we start fludrocortisone, right? But in shock, we can start both together. And there is a study that's called approach study. They have used this combination and they found there is mortality benefit. And there is a trial, adrenal trial, where they have used only hydrocortisone and they have found that there is no mortality benefit, but there is earlier shock reversal, less ventilator deaths, right? This adrenal is produced in NEJM 2018, approach also produced in NEJM 2018, right? So whatever you may choose to use. Number 3, where mineralocorticoid action is required, cerebral salt wasting, especially in TB, meningitis and subarachnoid hemorrhage. Remember, here the mineralocorticoid receptor will not enter the brain and act. This will act in the periphery, right? Here also, because here the salt is wasted, we want only the mineralocorticoid action, not the glucocorticoid action. So here hydrocortisone will not be a better drug because it has GC plus MC. So here we will use fludrocortisone, which is a 100% mineralocorticoid. That is fludrocortisone. The dose is 0.1 milligram per day, right? And this is because in cerebral salt wasting there is natriuresis driven loss. So here DEXA will not work, DEXA won't work, hydrocortisone won't work. Hydrocortisone may work because it has some mineralocorticoid action, but it will not be sufficient. So fludrocortisone 0.1 milligram per kg, the best drug in cerebral salt wasting secondary to TBM and SAH. Number 4, where we use it? In hypoaldosteronism, that is type 4 RT renal tubular acidosis with increased potassium. Here also, because there is hypoaldosteronism, we do not need glucocorticoid action. We need only mineralocorticoid action. So here also, the drug of choice will be fludrocortisone, right? 0.1 milligram per kg. Now, second, coming to the glucocorticoid receptor activity. So first is stress coverage. Stress coverage or immunosuppression. Here we have 3 use. Number 1 is in refractory septic shock. This is the reason why we use hydrocortisone, because hydrocortisone has both glucocorticoid receptor activity and mineralocorticoid receptor activity, and both GR and MR increase the vasoreactivity. So stress coverage, here also stress coverage. That's why hydrocortisone is the drug of choice here in refractory septic shock, right? Second, in secondary and tertiary adrenal insufficiency, as you've discussed, here the aldosterone is spared because aldosterone is not controlled by pituitary or hypothalamus. So here we do not need aldosterone activity or mineralocorticoid activity. So here the drug of choice is IV hydrocortisone. Now you will ask why IV hydrocortisone? Hydrocortisone has mineralocorticoid activity, but we do not want it because here aldosterone is spared. Hydrocortisone is chosen because it is only naturally occurring steroid. It follows a circadian rhythm. We give it 50 milligram TDS or QDS. So it follows a circadian rhythm. So despite being having some mineralocorticoid activity, it is still chosen in secondary and tertiary AI because it follows the circadian rhythm and naturally it is naturally occurring steroid, right? This is the reason. Otherwise, pure glucocorticoid may help you like dexa and methylprednisolone, but they are long acting and they do not follow the circadian rhythm, so it will not be very effective, right? Number three is immune checkpoint inhibitor. Here also we use as a immunosuppression. Uh, if there is respiratory failure, methylprednisone or methylprednisone is generally used, right? Then second, we have anti-inflammatory activity, right? Or this is also called disease modifying in acute illness. And all these things are evidence based, right? Here the choice of steroid must have some glucocorticoid activity because that is anti-inflammatory. And all the choices like dexa, methylprednisolone, hydrocort are evidence based, right? So you cannot just pinpoint why we are using dexa in some case, why we are using solumetal in some case. And there are studies and they have proven us that this is better for this disease, right? So here because we are talking about inflammatory, so pure mineralocorticoid like fludrocortisone is will not work in this case, right? So what are the diseases we have? Number one, severe community acquired pneumonia requiring ICU admission, right? Here there is a study, the CAPE COD study published in NEJM 2023. They suggested hydrocortisone 200 milligram per day. Continuous infusion is better than intermittent boluses. And they have seen in the CAPE trial that the 28 days mortality is decreased when we use hydrocortisone in severe CAP admitted to ICU. Number two, moderate to severe COVID ARDS. And based on the recovery trial, which is the latest trial, here you use dexamethasone 8 milligram per day into 10 days. And some follow the dexa ARDS trial and that suggests uh, 20 milligram per day into 5 days followed by 10 milligram per day into 5 days, right? Whichever you prefer. We usually prefer dexa 8 milligram per day into 10 days, right? Number 3 is AECOPD and number 4 is bronchial asthma. In both the cases the steroid of choice is methylprednisolone or prednisone. The reduced trial suggests that a 5 days course is enough, right? 5 days course is enough. The dose is usually methylprednisolone 40 milligram per day, right? Number 5 is PJP, pneumocystis pneumonia, right? If patient is hypoxic, you have to add steroid. Here the steroid of choice is same, prednisone or methylprednisolone. Dose is same. Number 6 is bacterial meningitis. It is very, very important, especially the streptococcal meningitis or pneumococcal meningitis. The drug has to be given before the antibiotic or along with the antibiotic. And here the preferred steroid is dexamethasone. Right? Dose is around 10 milligram IV QDS. But it has to be given along with antibiotic or before antibiotic. Otherwise, it won't work. Right? Now we have a third action here, the glucocorticoid action. That is the anti-edema action. Number 3. Here we have few indications because the glucocorticoid receptor mediates the anti-edema action, so pure mineralocorticoid cannot be used here. Or rather, the pure mineralocorticoid like fludrocortisone or hydrocortisone, they will retain water and sodium. They will flare up the and edema in the patient, right? So all these uh, diseases that require MR, you have to be careful of fluid overload, right? Hypokalemia, etc. So especially in CKD patient, in heart failure patients, we have to be very, very careful, or it can also exacerbate hypotension. So that's why in anti-edema action, pure mineralocorticoids are, or any drug having some mineralocorticoid action is contraindicated. So here we have number 1, brain tumor or metastasis in brain. So the drug of choice is dexamethasone, right? 4 to 8 milligram per day. And remember one principle. That principle is only and only dexa crosses blood-brain barrier. So whenever brain is in question or spinal cord is in question, the answer will be dexa because it is the only steroid which has adequate penetration inside the brain. Also, it causes less delirium. Right? So this is the principle. Number 2, metastatic spinal cord compression that can also cause edema in the spinal cord. There also you can use dexa. Here the dose is a little bit different, 16 milligram per day. So all these doses you can find in the internet in the Medscape. You have to understand the concept, why you are giving and when you are giving, why you choose specific steroid in specific situation, right? Number 3 is post extubation laryngeal edema or prevention of stridor. Remember here we have to give the dexa beforehand. It is 12 to 24 hours before extubation, right? So here we use dexa. Also you can use methylprednisolone. We've studied in both of them. So methylprednisolone has minimal mineralocorticoid activity, so can be used in post-extubation laryngeal edema to prevent it and prevention of stridor, right? Also, of course, dexa is the drug of choice here. Another thing to remember is never use it in traumatic brain injury related edema. it increases mortality, it causes harm. So in crash trial, they have given methylprednisolone and they found out patients who receive methylprednisolone are dying more than the patients who are not receiving methylprednisolone, right? So never give steroid in traumatic brain injury. So if you summarize, when there is shock, there is vasoplegia, there is on vasopressor. Here we need mineralocorticoid action along with glucocorticoid action, because glucocorticoid and mineralocorticoid both increases the vasoreactivity, right? In inflammatory, where there is cytokine releases and all, we discussed, we need more of glucocorticoid activity than mineralocorticoid activity. In communicable pneumonia, in ARDS, in asthma, in COPD, in PJP. So here we choose methylpred, dexa, prednisone, all these things. Here you choose mainly hydrocort plus minus fludrocortisone. Need sustained immunosuppression. See, hydrocortisone has glucocorticoid activity, but its half-life is very short, so it won't produce a sustained immunosuppression, right? For example, immuno checkpoint inhibitor, we're using methylprednisolone. Why? Because they have a long half-life and they produce sustained immunosuppression. So here, avoid short-acting steroids like hydrocortisone, although it has glucocorticoid activity. Of course, if you are giving infusion, that's a different thing. It will work round the clock, right? For CNS edema, as I've discussed, only dexa penetrates the brain, so use dexamethasone. In airway edema, both dexa and methylpred are preferred based on the studies, but it has to be given beforehand, at least 12 hours before extubating, to prevent stridor or prevent post-extubation laryngeal edema, right? Also in primary adrenal insufficiency, the aldosterone is gone, the cortisone secretion also gone, so we need hydrocortisone, which will provide both MC and GC, and when we wean the patient to oral, we can start fludrocortisone, right? In secondary AI, aldosterone is spared, so we do not need fludrocortisone. We do not need hydrocortisone also, because hydrocortisone has mineralocorticoid activity, which we do not need here. But we use hydrocortisone because it is naturally occurring. It's naturally occurring steroid. It follows circadian rhythm, right? Dexa, methylpred are long acting, so they do not follow circadian rhythm. So the outcome with hydrocortisone is better. So both in primary AI and secondary AI, hydrocortisone is the drug of choice. In the primary AI, you can wean the patient to oral fludrocortisone. In secondary AI, we do not need fludrocortisone. So this is in a nutshell approach to steroid in ICU. Thank you very much.